Good morning, everybody. As you can see, I'm chairing today, which is a slight change of agenda. I was informed last week that we have a change of the chair to Councillor Evil Shelvin, thank you. But unfortunately, he sends his apologies today because he had a prior arrangement which couldn't be moved. And therefore, as Vice Chair, I'm chairing today. I'm going to have a meeting with the new chair next week, and we're going to have a talk about how things work going forward. Thank you. So, welcome to the Health and Wellbeing Board meeting. What I thought we would do this morning is just introduce, because we seem to get slightly different members, certainly from the voluntary sector each time, and it would be good just to go around the room and do some introductions, if that's okay. So I'll just start over here.
Outside. Can you hear me now?
Try the right hand side.
Try the right. Is that better?
Yeah. You have to look at it. Yeah.
You have to look at it, right. My name is Christine Wardlaw. I'm here representing North of Tyne Local Pharmaceutical Committee, which represents community pharmacy across Northumberland, Newcastle, North Tyneside.
Thank you, Christine.
I'm Julie Boyack. I'm representing the volunteering community sector.
Hi, I'm Jeff Watson. I'm a Cabinet Member for Healthy Lives for Northumberland County Council.
David Thompson, Health Watch Northumberland.
Jane Lothian, I'm the lead officer for Northumberland Local Medical Committee that represents all GP providers in the county.
I'm Liz Morgan. I'm the Director of Public Health and the Interim Executive Director for Public Health and Community Services.
I'm Anne Everton. I'm a guest for the day and I wrote the pharmacy needs assessment.
I'm Glenn Sanderson. I'm leader of the County Council and I haven't written anything of value at all.
Good morning. I'm Siobhan Brown, Chief Operating Officer at the Clinical Commissioning Group.
I'm Leslie Bennett from Democratic Services.
And I'm Graham Sires, Clinical Chair of the CCG. And can I just check at the back?
James Robinson from the Chronicle.
Thank you very much. Terms of reference. And I think that's something that I will be going through with the new chair. And just to make a reference to, as things arise on our agenda, which bit of our terms of reference do they apply to? And that is going to be more important as we go forward with the changes in the health sector and how those organisations are changing as well. Item 2, apologies. Sorry?
Sorry, could I just ask, where are we with the joint health and wellbeing strategy?
So we had a new joint health and wellbeing strategy which was signed off by the Health and Wellbeing Board at the end of, in 2019, end of 2019. We had some fantastic aspirations about bringing the joint health and wellbeing strategy to the Health and Wellbeing Board regularly, but that was sort of pushed out of kilter by the pandemic. But what Graham and I discussed yesterday was that one of the things that we do need to do is to, as a board, is to re-look at the joint health and wellbeing strategy in the context of COVID and the impact that that's had, and just seek reassurance amongst ourselves that the priorities in that strategy are still the right ones.
Thank you. Okay.
Right. So is that okay?
I think what we discussed yesterday and what we need to discuss with the new chair is the work that we did with the board a couple of years ago now to review the terms of reference and review the way that we did our business. And the original intention was that we had fewer meetings, but we interspersed those with some developmental workshops. And we didn't manage to do that because of COVID and the roles board in acting as the COVID control board. So we ended up going back to monthly meetings and talking a lot about COVID. But I think one of the things that we do need to do is to, in the not too distant future, is have a development session which looks at the joint health and wellbeing strategy, refreshes our outlook as a health and wellbeing board and refocuses our attention on what we think we need to be doing going forward. And also gives us an opportunity to have a bit of a discussion about things like the integrated care system and where we think the health and wellbeing board is going to fit into that in the future.
Yeah. Good, thank you. Thank you. What we'll do, we haven't even got round through apologies, so I'll mention that in the forward plan, and then we'll just formally agree that that's something that we're going to pick up on. I think, if that's okay. Perfect. Right. So apologies for absence, Leslie.
Yes, we have apologies from Councillor Eshiel Shelvan, Patterson, Renner Thompson and Simpson, and Paula Mead, Graham Writer and Pam Travers.
Thank you. The next item is the minutes of the previous meeting, which I have here. Can I just check for accuracy? Is everybody happy with page 1, page 2, 3, 4, 5, 6?
Graham.
Yeah, Jane?
There's an issue, and I've looked at this several times. It's on the item to do with the child death overview panel.
Okay.
I raised an issue about the attribution of area for the deaths, because there are a disproportionate number attributed to Newcastle and to Northumberland, and the report author could not was not in possession of the information.
Yes.
Because they were attributed at it appears they were attributed at the place of death.
Yeah.
Which would have been either the paediatric intensive care at either of our two trusts.
Yes.
So I think in terms of a very important piece of public health information, inappropriate attribution to the place of death rather than the place of parental or residency. I can't see it's been
Recorded.
I suggest it's recorded because it could give a very, very skewed
Yeah, I understand.
impression.
Okay.
Chair, I'm happy to pick that up as an action.
Perfect, thank you. So could we mark that down as an amendment to the minutes with an action that Siobhan will take away and pick up with? It was Alison that presented the paper. Thanks, Jane. So that was page 6 and page 7. Thank you. So I'll sign those off as accurate with the amendment that we've discussed. Item 4, are there any disclosures of interest that anybody wishes to bring up? No, thank you. Therefore, item 5, living with COVID, and this is a verbal report now.
Yeah, thank you. And these are getting shorter and shorter as time goes on. As I've said before, the main source of information for us now is the ONS surveillance study, which reports once a week on a Friday. It looks at retrospective data and it's an estimate of prevalence based on a quite big sample of testing done across the UK population. So the latest data that we have is for the week up to the 30th of April, and what that data shows us is that the estimated prevalence reduced from 1 in 25 to 1 in 35. So over the course of a few weeks, it's reduced from over an estimated 4 million cases a few weeks ago to just over 1.5 million cases in that week up to the 30th of April. But obviously that still represents a very high high number of cases. In the northeast, we're slightly higher than the England average, so the estimate is about 1 in 30. There is quite a range of prevalence in terms of age groups. So in primary school age children, the estimated prevalence is 1 in 66, and that goes up to 1 in 29 in people over the age of 70. But it is an improving picture and a very similar picture to what is being seen in other areas of Europe. The information that I have from the Trust is that the numbers of people being admitted with COVID, not necessarily because of COVID, and the number of people in hospital with COVID are reducing. I think overall sickness absence in sort of key staffing groups is reducing. I know from a conversation I had with our Director of Education this morning that schools are still under a bit of pressure in terms of staffing absence, but I think overall things are going in the right direction.
Thank you. Does anybody have any questions on that point? Councillor Watson.
What would a previous experience has said that when there's been a school holiday, like Easter break or summer holidays, we've seen the amount of infection go up? Has it happened this time, or has it been managed to stay level?
No, I mean, the data from the ONS study just suggests a sort of gradual drop-off of cases. So at the highest, I think it was about sort of 1 in 13, 1 in 14. And then it went down to 1 in 17, 1 in 25, 1 in 35. So there is just a gradual fall of cases. But you're right, normally the holidays normally provide a sort of bit of a natural fire break in terms of transmission. But I think it was probably, case rates were probably falling anyway.
Could I ask about the immunisation programme at the minute? And any reflections on that, how that progresses still?
Yeah, I mean, I think clearly overall that, you know, the programme has just been hugely successful. The vaccination programme at the moment is, well, the newest thing is obviously this sort of booster, 4th dose in people over the age of 75 and certain groups of individuals who are immunosuppressed, etc., etc. You know, I think uptake is not as great as we would like it to be, certainly the regional vaccination centre, I think, are working hard to make sure that you know, the vaccine is getting into the right place at the right time. But we have agreed that we're going to focus on care home residents as a priority with the vaccine that we've got available.
Can I just mention around the vaccination programme, there seems to be, as we offer the programme in pharmacy, confusion with the public. There's comms, a lot of, especially as we've now started to do the paediatric age group, a lot of parents, they've received their letter of the NHS, but they're hanging back, waiting to be contacted by their GP. And so we're seeing a poor uptake of the service. And I mean, to be fair, Newbiggins, one of the areas, if you look on the social media group chats, a lot of parents are commenting on that. And on Saturday morning, I actually had a lady who'd travelled for 2 hours on a bus with a 5-year-old from Newbiggin to come to a clinic in Monkseaton. I mean, she had to be applauded for making that effort. But I think there is a comms issue around in parents' expectation.
Thank you. I'll come in on that for a second. I met with the primary care network leads yesterday, and there is still some difficulties in terms of the process of obtaining the vaccines. So despite people being informed by an NHS reminder system that they are due for their booster, unfortunately some of the local vaccine sites still find it difficult to have timely access to the vaccines, and therefore people are then left to looking around the NHS booking system, and they find that the only vaccines available are at some distance from where they are, despite being asked to get a vaccine. It has been escalated to our regional vaccine system. It's not something which is unknown, but it does seem a pretty difficult problem to solve, this matching the supply of vaccines to the places that are able to give them.
Sorry, Graham, adding on to that, the problem is with the vaccination ordering system is a 2-week lead time. So you have to order at least 2 weeks in advance before your delivery will be confirmed. So then it is, you know, people are getting their letters and then they're maybe having to wait 2 or 3 weeks before they can find somewhere that's got supply.
Okay, interesting to hear it from the pharmacy side as well. It has been difficult to get that working arrangement between the pharmacies and the local vaccine centres as well. Yeah.
Yeah.
Okay. Councillor Watson.
I'm a little bit confused because all the time that we've had the vaccinations, people have been told at that age group that they're going to qualify for, you've always had two options as far as I could see. One, you could go out and try and do it yourself and join one of the clinics and one of the centres, or you could simply wait. And then you'll be contacted by a GP, which is what I've always done. And I don't think it's any difference now. So the people who've been told that they're entitled to it, if they simply wait, they will be told by the GP. Have I got that wrong?
No, that's correct. When the local centres, so your GP in your case, but it's not everybody that their local centre is run by their own GP, so that's a slight difference. But when they have access to vaccines, they usually look down their list of the people that they know are still waiting for a vaccine, and they would contact them to let them know that they can now book. So that seems to be how it would work. However, it does seem that there is a difference sometimes in the rates that some centres manage to get vaccines to others. So some people are left wondering why their practice or their vaccine centre has contacted them, yet theirs hasn't. And this is to do with the difficulties in the distribution of the vaccines.
Yeah, I'm aware of that, Graham. Thank you. And my advice to people who rang me was always, well, just wait, and you will be contacted, and you don't have to run around the country to do it. You're a little patient. That's what I've always said, and I think I'll continue saying from what you're saying. Thank you.
Thank you. But I think it is fair to say that there is still lots of work going on to try and ensure that we get the vaccines that people need. So it's not that there is any sitting and waiting for this. We are still asking, and there is still capacity to give vaccines in Northumberland. Okay, Jane?
I just wanted to... because I'm not within the NHS system as such, that the CCG, and in particular, I think thanks go to Richard Hay, who has worked tirelessly as the operations lead for the entire vaccination programme, that he is almost driving around Northumberland, no, not quite driving around Northumberland with them in the back of his boot, but he is day by day having to distribute what he gets. And they don't know virtually till the last minute what they're going to get. And then he's having to equitably distribute this around the county to both pharmacies and doctor and GP centres and other vaccination sites. So I think whilst unfortunately there is a central push to say, here's your letter, so there's absolutely no connection, it's which people don't realise, Councillor Watson, there's absolutely no connection between the letters that are coming out and the delivery. So I think it's very, very difficult for people, and it's very, very difficult for the official communications to be able to relay this to the population in a timely manner. And I think anything we can do through councillors, etc., to say they will get it in the end, and as you say, just wait, and somebody will, you know, or they can try and do it themselves if necessary.
Okay, thank you. I'm going to draw this to a close, but I think we've illustrated quite well some of the difficulties that are still occurring in the vaccination programme. But just to highlight the point that Liz finished with, is that at present the focus is on care homes. Yeah, thank you. I move us on. Thank you. So we are now to item 6, which is the Pharmaceutical Needs Assessment Update, and this is Anne Everden, and this is for us to receive the draft and then agree for it to go to formal consultation.
Indeed.
Thank you.
Very much.
services to go alongside this, and their reports will feed into the final document, which has to be signed off by the 30th of September. So we have got Health Watch doing some focused work in those areas where we have seen pharmacy closures, because we want to ensure that there is still adequate pharmacy services in the areas where we've had closures. And that would be Alnwick, Hexham, Bedlington Station. Initial feedback is that people are happy with pharmacy services. We have had some concern about the pharmacy in Alnwick closing at lunchtime, and I think it's a play-off between staffing and what I've heard back from the pharmacy in the town centre in Alnwick is that they have had staff difficulties due to COVID, but we would like to see them making sure that there is some cover at lunchtime, because people who get buses into Alnwick to access those services sometimes find the pharmacy is closed before their bus returns. So that is an issue that does need to be addressed, but I don't know that the PNA is the way to address it, but we'll bring it to the attention along with anything else that comes out of the consultations. It will go out to public consultation as soon as I get the nod that it can go out. So hopefully from Monday for 60 days, as is required. And thereafter, I will write a report on the results of the consultation and the result of the work that Health Watch has done, and that will be fed into the final report, which should come to you for your September meeting, if I can get everything done in time. But it will have to be signed off. But I'm working very closely with Liz to make sure that we get the final draft through the various stages so that it does hit the September meeting. I think the only other bit of note is that it may be contentious that we haven't put in a request for an extra pharmacy in Cramlington, but there's no way that it adds up to have an extra pharmacy. I've discussed this with NHS England, and their view is that to allow an extra pharmacy, you need something in the region of 10,000 extra homes. There are not 10,000 extra homes being built in Cramlington, and certainly there is no plan to build close to the campus such that people would be stopped from getting services by the spine road. And without those things, NHS England, no matter how much we said we would like another pharmacy, will just turn around and say, you've got sufficient pharmacies in working hours to meet the needs of the population. And if we were to allow another pharmacy, there would be an oversupply of essential services during normal working hours, and therefore they wouldn't grant it. So I have taken external advice from NHS England before coming up with that solution to a potential problem.
Thank you. I'm going to ask David if he has any specific comments on this, given that he's Health Watch are involved in this, and I was going to come to Christine as well for any specific comments from an LPC perspective, and then I'll open it to the floor. David, are there any specifics you'd like to raise?
No, nothing in particular. It's just that I think at the latest count there were 267 responses to the survey, which is a very encouraging number, and I think sufficiently broad and deep to make any conclusions worthwhile. So we were delighted to help, but that's what Health Watch can do. I think it's an important lesson generally that Health Watch and other organisations can communicate with, engage with the wider community, and if need be, come up with meaningful responses. So it's we were delighted to do it, but that is what we were supposed to do.
Yeah.
The only thing I might add is when you look at the report, I know it's on assessment, but there is an increasing range of services provided by pharmacies, you know, which is all to the good. We heard before about the vaccination one, but how well informed is the public about this increasing range of services? I know it's not directly related to the agenda, but just thinking about it, there's a lot going on there. And do members of the public know the range of services which are available to them, which therefore might help take pressure off GPs and so on? It's a communication exercise, as it often is.
It is a communication exercise, and it is something that the steering group did consider. However, we thought that our first focus must be to deliver the PNA in the legislated timeframe, but it did recognise that there is another piece of work to be done after we have delivered the pharmacy needs assessment, which is a communications exercise about the hugely increased range of services available through community pharmacies, and encouraging the public to use pharmacy as a first stop to relieve the pressure on GP practices and A&E departments. So if we are allowed to, we will work on part 2, which is a communications exercise with the help of the local pharmaceutical committee, I hope, who would be well placed to use the information they have at their disposal and therefore be slicker at getting that information across to the public. So let us hope that we are allowed to continue and provide that information together.
Yeah, thank you.
Thank you, David. Christine?
Yeah, is my mic on? I don't know.
Yeah.
Yeah. I think the only thing I want to get back to is the point around ANIC closing for lunchtime. In community pharmacy, we're having real issues trying to manage patient expectation. You know, obviously all the workforce pressure, and the pharmacy will only have one pharmacist on site. So they are, you know, the lunchtime break is not part of their core hours. And I understand, you know, people have travelled some time. It might be that the pharmacy need to be advertising more, that there is going to be a lunch break. But, you know, I think we are finding trying to manage patient expectation is a huge issue.
Can I just make a rejoinder to that, in that when we allowed the 2 pharmacies in the centre of ANIC to combine, it was on the understanding that they provided a good service for the patients of ANIC. And so we would have to review our decision that it wouldn't create a gap if they combined the 2 Boots branches in the centre of ANIC, because the Health and Wellbeing Board did consider that at a meeting and said that they should guarantee, and I was told that there would be 2 pharmacists in that branch, one working upstairs on stuff and one working downstairs dealing with the public and the prescriptions as they came in. So, if you like, they're reneging on their deal to allow the 2 branches to combine.
Yeah, I'll make note of that, Anne, and I'll obviously take that back to the committee.
Yeah.
And to Anne she'll no doubt contact the relevant parties.
Yeah. So, I mean, yes, and it's not the only... I do understand about pharmacies having difficulty because there is the mental health and them getting a break at lunchtime, which everybody should be expected to be able to have. But in a pharmacy that was allowed to merge or consolidate, or whatever the
wording is,
it was, I mean, I did go up and talk to the branch managers at that time, assuring me that they could cope with the workload that closing one branch would have.
That's fair enough. But aside from ANIC in general, we are finding trying to manage patient expectation. You know, the patients are not giving adequate time for ordering their prescriptions, which then has a knock-on effect. Obviously, there's a lot of stock issues at the minute, which is beyond the control of community pharmacy. It's become under control of the NHS. So there is real pressure on pharmacies to manage that expectation.
I think as well that is a communications issue which needs to be got across to the general population in very rural areas which are dependent on rural bus services. And that's the only thing that I've heard back, is that in very rural areas where the bus services are very rare and timely, that it's really important that it is communicated if there is not going to be a pharmacist on duty in the middle of the day.
Okay, thanks. I've got Councillor Sanderson and then Liz.
Thank you very much. I suppose the question really is how many other pharmacies close for an hour at lunchtime as a general rule? Because whilst I understand it's important for people to have a break at lunchtime, it's often that break there where people have their lunches as well, and they go out and need to get some service. So I just wondered, it does seem very unusual to me that in this day and age that you would close at lunchtime. The second thing is around ensuring that we have sufficient out-of-hours cover as a county, and I wonder if you could explain where we are with that, and is there a sort of strategy that the pharmacists have agreed between themselves to have certain parts of the county covered by an out-of-hours pharmacy service, or is it just done on a sort of ad hoc basis?
We rely on pharmacies which have to open for 100 hours a week. Way back in about 2002, the government thought it would be a great idea that it would allow anybody to open a pharmacy provided it stayed open for 100 hours a week. We have 5 of those pharmacies spread across Northumberland, and we rely on those pharmacies for out-of-hours care. And they're all open till approximately 10 o'clock at night. Often open from pretty early in the morning. And again, this is again something that the government didn't think about when they said you can open for 100 hours. Most of these pharmacies are situated inside supermarkets, which the government insists can only open for 6 hours on a Sunday. So to get their 100 hours in, they open very early in the morning, when possibly it's not needed, but it means that we have a shortened time on a Sunday when pharmacies are open. In Northumberland, we are actually very lucky because we have 2 pharmacies which are not in supermarkets, and they open till 8 p.m. on a Sunday. So we are, in comparison to the whole of the North East, actually very well covered. And they are geographically spread out. So we have 1 in Berwick, we have 1 in Hexham, and we have Blythe, we have Ashington, and 1 in Cramlington. Thank you.
Okay, thanks, Anne.
Can I just come on? Sorry, the first point, which is around, is it not unusual to have pharmacies that close at lunchtime, or is it sort of relatively common?
It has become increasingly common. If you think, the trouble is the pharmacies don't close at lunchtime, but there is no pharmacist on duty. And that is what really confuses the public, in that in the olden days, and I'm going back to when I was a very junior pharmacist, you did close the whole pharmacy at lunchtime for an hour. But as you've said, people are busy, and it became much more the norm that pharmacies would stay open all over lunchtime. But then the pharmacist didn't get a break. And that is very difficult if you are very, very busy all day, that you don't get a break at lunchtime, because everybody's entitled to one. And unless it was a very, very busy pharmacy, there wouldn't be 2 pharmacists on duty. There is now a shortage of pharmacists working in community pharmacy that employers have had to move to what we'll promise we'll open between 9 and 1, and then between 2 and 5:30 or 6 o'clock, just to keep the place staffed.
So if the government are saying they want pharmacists to take on more, which I believe is something within the Queen's speech, how's that going to work then if there's already a shortage of pharmacists?
There's a shortage of pharmacists in community pharmacy because a lot of them have now moved to working in GP surgeries and for clinical commissioning groups. So there are lots of pharmacists about, but they're not necessarily attracted to working in community pharmacy. But I think the LPC would be more able to give an up-to-date picture.
Subject.
This is it. We could spend a whole morning, I suspect.
Sorry.
And in some respects, it's a really good discussion, is this, because it's highlighting some of the issues. I'll come to Liz in a second. There's a practical example of what you've just talked about, out-of-hours pharmacists. So for somebody in ANIC, the pharmacist shut at 6 o'clock. My surgery keeps seeing people till 6:30. On rare occasions, I might see somebody at 6:10, and I think they need a prescription this evening. I have got an option of waiting till tomorrow. In that situation, the nearest pharmacy to an ANIC resident is Blythe at that time of night. It's the ASDA pharmacist. So I will normally have a discussion with the patient. It's often a child, and so it's often a parent. Would you be prepared to travel because I think you need to have this? I will ring the pharmacy to check it's in stock before I make a decision to prescribe, and then I will send an electronic prescription to that pharmacy, and the parents will go down and pick it up. So it's a relatively rare occasion, but there are some occasions where people need to travel some distance in the evenings, and it's an illustration of our rural environment. It will not happen to the person in Newcastle because Tesco on the north side is always open. You know, so these are the practicalities that Anne is talking about, and it is managed to cover, but there's usually a clinical discussion about the risk of waiting for a pharmacy to be open, and it will happen with the out-of-hours doctors as well when they want to prescribe something on a Sunday evening at 5 o'clock when the pharmacies are closed.
Apart from in Northumberland, where you can get a pharmacy till 8 o'clock.
Okay, we'll come to Liz, I think. Thank you.
Yeah, I just wanted to pick up the comms issue really, and is there an opportunity for us to work with yourself to pull together some information to send out to the public?
Yes, I think it definitely is. It's, you know, I mean, I think our experience is it's just constantly drip feeding to the public around, as I say, manage their expectations, talk about additional services. NHS 111 obviously does a lot of work around directing people, but there's always the need for extra comms.
Okay, so we'll I'll drop you an email.
Yeah.
I'm looking around the room. Jane.
Just to say on that matter, Liz and Christine, the local medical committee and Health Watch have already had some discussions with Geraint Morris and Anne Gunning about that precise issue about comms around services.
So can we agree to accept that report in its draft form and that it can now go out to formal consultation? Thank you.
Thank you.
Thank you.
Thank you. Thank you very much. It's a big document and there's an awful lot of work goes into producing that, so I recognise that.
That's really good.
Thank you. So item 7, oral health strategy update, and I think this is Liz.
Yes, it is. Thank you very much. So I think everybody here will recognise that poor oral health can have a significant impact on speech, on somebody's ability to eat, on their social interaction, on their confidence, and certainly if you're experiencing significant oral health issues when you're a child, that can have an impact across the whole of the life course. So oral health is a really important component of our overall health and well-being. The existing oral health strategy that we've got in place, which ran from 2019 to 2022, is based on a very comprehensive dental health needs assessment or oral health needs assessment, which was undertaken in 2017, and it identified 14 areas of action pulled together under 4 themes. The pandemic has obviously had a significant impact on our ability to deliver the strategy. It's restricted our ability to do the actions that we wanted to do. Access to dentistry has been significantly reduced during the pandemic, and obviously public health capacity was really focused on the pandemic response. But actually, the Oral Health Strategy Implementation Group, which is a group of stakeholders who are responsible for developing and delivering the strategy, have worked really hard over the last 2 years to make sure that we have had as much impact as we could have in the circumstances. And that group includes dental colleagues, Health Education England, the Office for Health Improvement and Disparities of Public Health England, as was the Integrated Wellbeing Service, Northumberland Communities Together and Northumbria Trust. I think in terms of achievements over the last couple of years, a couple of things that spring to mind. Really important, and something that which I know has been really appreciated by those in receipt, is the ongoing distribution of toothbrushes and toothpaste to those in need. I think that's been particularly important in view of the financial pressure which is increasing on families. We've still been able to deliver a lot of training that's been delivered through both Health Education England, but also work packages which have been developed by the Integrated Wellbeing Service, and those have supported both people in contact with young people, but also training delivered to care homes, because oral health is just important in older people as it is in younger people. I think also that the fact that we've moved to remote meetings has actually been a huge advantage, because whereas dental colleagues in practice struggled to get to the stakeholder meeting, actually they were much better able to contribute because they didn't have to leave their practice to come to a meeting. So that's been a real advantage. I think that the Health and Wellbeing Board will obviously be interested in plans for fluoridation, because you'll remember that back in 2019 we were working with 3 other local authorities to look at varying the community water fluoridation scheme, and we'd got to the point where we were going to go out to consultation, but then of course that was all thrown into disarray by the pandemic. That pandemic is probably not a great time to go out to consultation on that sort of issue. And actually, in the interim, the Health and Social Care Bill will effectively transfer all of the local authority responsibilities with respect to fluoridation to the Secretary of State. So what we have done is the leader wrote to the Secretary of State last August to make sure that we were at the front of the queue in terms of taking fluoridation forward when the Health and Social Care Bill goes through. And more recently, we have had a very early conversation with the Department of Health and Social Care, so that as soon as that bill goes through, we will be having a conversation with them about how we take forward a variation on the current community water fluoridation scheme across Northumberland and the other 3 local authorities. The recommendation in the report really is quite simple. It's just to extend the existing strategy until 2015 and continue to work on those 14 recommended areas. The Oral Health Strategy Implementation Group is sort of constantly looking at those actions to see which ones that we can start to do more work on, and obviously as things progress back to something which is nearer normality, we'll be able to pick up more and more of those things that we've had to put on the back burner for the last couple of years. So that's pretty much where we are with oral health, and I think the big thing for us will be to pick up the community water fluoridation and take that forward at the earliest opportunity.
Thank you very much. I'll open the floor in a second. I'll come to you in a second then. I'm thinking about Julie in the voluntary sector, and I'm thinking about the very needy people in Northumberland who might be accessing food banks, for example. So if you can't buy your food, can you buy your toothpaste? And is there a way of us making sure that the food banks have toothpaste and toothbrushes? Over to you.
That was exactly my point. It was actually on the national news yesterday. They were interviewing a number of local dentists who were saying that because of the poverty crisis that's going to hit and is already hitting local communities, the first thing to go is oral health, quite often because toothpaste and toothbrushes are an actual luxury for some people. So obviously that means the position around oral health is going to get worse. I just wondered, I only mentioned that you were supporting some areas around oral health. I'm not sure what they are or what communities it's going to, but just like you've said, I was going to mention things like food banks. Is there any way we could supply food banks with toothpaste and toothbrushes? It's because the crisis hasn't even started yet, really. It's going to go on for a couple of years, and we really must think about those people who are suffering the most health inequalities usually anyway, and this is going to impact even more. So I just wondered what your plans were to address those issues.
Yeah, so I believe, and I'll check, but I believe Northumberland Communities Together have been, so they've been part of our sort of distribution network, as have Shore Start Children's Centres or Children's Centres. But I will check that they have been linking into food banks, but I'm pretty sure that they have, but I'll check that one.
Thank you. Before I come to Councillor Watson, I'm just reflecting on my use of language there. I said needy people, and I want to retract that because I think we should be better off talking about people who can't afford to buy or that side of thing. I think it labels people incorrectly, and I'm not happy with what I said then. Thank you. So Jeff and then David.
Yeah, you brought back some memories there when you were talking about the fluoridation discussions that we'd had 3 or 4 years ago. I think I must have been chair of the board or something at that time, because it was a very confrontational discussion, and it took a long time, and we did a lot of work on it. I'm totally convinced from the work that took place at the time that we should go ahead and do fluoridation, and the board or the committee or whoever it was I was chairing were 100% committed as well. My concern is that if the government are going to take this and do it, are we going to have to go through all of that process again of consultation and discussions, or can we actually go ahead and do it? Because it seems to me, in a time when people are finding difficulty to pay for toothpaste or pay for toothbrushes, putting fluoride in the water costs them nothing and has a great deal of good effect on teeth health. So that would be my question. Hopefully we don't have to go through the whole rigmarole again, Liz.
Well, I'm afraid I'm going to disappoint you there. And it was the Overview and Scrutiny Committee that we had that discussion at. I remember it very vividly in the council chamber. So there will still be a requirement for a formal consultation, but it will be the Secretary of State who is responsible for doing that consultation, not us as a local authority, although of course we will want to support that consultation process as much as we can. Now, interestingly, the government is at the moment consulting on the consultation, and one of the questions that they've asked is whether, they've asked our views on whether we think the consultation to various scheme should be extended to people who aren't directly affected by the variation, and Councillor Wendy Patterson, as the portfolio holder for adult wellbeing, and myself agreed that, or our response was that actually we thought that the consultation should be restricted to those people who are actually affected by the variation rather than anybody else, because the danger is that you could have an organisation from America commenting on a consultation to vary a community water scheme in Northumberland or Durham or anywhere else. So that's the response that we've put back. But yes, there will be a response. There will be a requirement for a formal consultation.
I just hope it doesn't take too long. And I experience when the Secretary of State does consultation, it takes even longer than it takes us to do it locally. So I'm just hoping we can do it quickly.
Yeah, I'm fairly hopeful that that actually this will be a priority for the Secretary of State, because the 4 Chief Medical Officers put out a statement last autumn about community water fluoridation, and I'm hoping that that was a sort of signal that this would be a priority once the Health and Social Care Bill goes through.
David.
Thank you. Thanks for the report, Liz, particularly the continuing actions, the 15 actions which were highlighted, which are preventative and very, very useful. But also in the report, I think on page 116, or the second page of the report itself, it does mention inequalities in oral health. And also, I think on page 131 of the document, it talks about access to dental services. So the question is, bearing in mind the difficulties which there are in some parts of the country, and I would believe some parts of Northumberland, with access to dentists, in other words, people moving into an area, there are no sort of national health dentists available, and so on, the waiting times, etc. To what extent are the issues about dentistry, numbers of dentists and so on, access to NHS dentists, how will that impact on your 15 actions, on your strategies, particularly since there are health inequalities in dental care, and the issues with dentistry is clearly exacerbating those inequalities in certain sections of the community. So how can what you intend to do actually be done, bearing in mind issues over capacity and access?
Yeah, so I mean, I think you highlight a really important issue, and I know that a report went to Overview and Scrutiny Committee a few months ago, and NHS England, I think, came and presented about dental services and the challenges facing the delivery of NHS dental care. I think there are, a number of routes that we can use to keep pushing on NHS dentistry, but I understand that as part of the ICS developments that there may be a shift in responsibility around the delivery of dental care at some point in the future. But it is a real issue. I think the issues are around the contract and what's in the contract and how much dentists are being paid, but also probably just a sort of lack of dentists.
If I could just come back, of all the issues which Health Watch nationally, regionally and locally have had from the wider public, dentistry has emerged in the last year or two as a very, very significant issue. And as you highlighted when you first began your presentation, Liz, oral health can have a major impact on people of all ages, of all socio-economic groups, confidence, employability and so on. This is a big issue, and I think at the moment the integrated care system are looking at this, but it's not under the remit of any local organisation in terms of the contract and so on for dentists. So it's at the moment, I think it's in a bit of a dark place, and I'm sure the integrated care system will pick it up, with very robustly as time moves on. But it is a very significant issue, and it is exacerbating health inequalities within the population of the county and the rest of the country. It's a big issue, this one.
Okay, thank you. Councillor Sanderson, and then we'll look to move on.
Yeah, thank you very much. So that point has been picked up, and it's one I raised with Liz 2 or 3 weeks ago, which is the oral health survey that showed Northumberland to be in a very bad position compared to other similar nearby authorities. Clearly the answer is fluoridation of water. There's no question about that. And I want to get this higher up on the political agenda because, as you know, this administration has some key themes. One is to support business. The other is to actually do what we can around inequalities. It's the first time the council has positively said this is going to be a direct aim and priority. So this is precisely the kind of thing that I want us to see us moving forward on. I agree the point about toothpaste to food banks, but that's not the answer, really. The answer is just simply to put a lot of pressure on the people who can make this happen and add fluoride to our water supply in those areas that don't have it. Full stop, simple as that. Liz, I'll raise this at informal cabinet next week because I do want us to kind of, if necessary, I will write to the Secretary of State myself if that'll help, just to underline our commitment and the need to do something about this. Thank you.
Thank you. Helpful discussion. So can we agree to accept the paper and its proposals? Thank you. So moving on, item 8, Population Health Management Quarterly Update, and that's Siobhan Brown.
Thank you very much, Chair. You'll remember last month we discussed as members the Inequality Summit and the actions now coming from that. What I'm describing to you today and the discussion that we're going to have are all part of the same landscape, just from a different lens. And I think there's a piece of work that we need to do when we look at the Health and Wellbeing Board future, when we look at the development of integrated care systems and the inequalities agenda here in Northumberland. All of these jigsaw pieces need to come together in a very coherent whole. And I'm aware that population health management, seems quite a management term, a bit technical, but ultimately I think what it's about is people and communities, and it's simply one of the tools that we have at our disposal to work with people and communities. So I want to make that real for you here today. A little bit from a health perspective, but I will draw in how the voluntary sector, our communities and the Inequality Summit work all fits together. But I think the fundamental thing here on the slides now is what we need to do, and it's to literally turn ourselves around in the way that we think. As organisations and statutory organisations, for a lot of years, a lot of decades, we are in the ball game of what can we do for everyone? How can we fix them? How can we get them in, get them out and fix them? And that's certainly true in the health environments around treatment. Everything we know now, we know that the £6 billion that's going to sit in this integrated care system here in the North East and North Cumbria, almost all of that won't actually impact on our health, our communities, and the way that we live happy, healthy lives. We know that it sits outside of treatment. So I think everything we do from going forward now is very much about, first question is about what do communities want to do for themselves? What then do communities need help with? And that could be resourcing, skills, other things to just get things going. And then finally, what do communities need outside agencies to do for them rather than the other way on, which we're so familiar with. What I want to just take you through now is to just make this a bit real, because whenever I hear terms like population health management, it's a bit cold, it can turn people off, but fundamentally I just want to describe one case that starts to show how this works. So here's a case study. It is definitely a real person. We've obviously got consent to share. It's anonymised. But basically, you've got a 41-year-old man here called Paul, who had a heart attack 5 months ago. He's worked his whole life, but is on benefits now. Lives in the tiniest flat you can imagine. He was abused as a child. He suffered from depression, but really reacted to antidepressants. Has come off those. And not that long ago, he lost his brother. So he's feeling really lonely, like he's got no one in the world. And fundamentally, and I mean, we've got GPs here in the room today, they'll see people like this all of the time. But the fact of the matter is, quite a lot of what Paul needs isn't going to be fixed by healthcare. So yes, he's on the cardiac pathways, but he can't drive, he can't get to the appointments. So what our thinking is now is, and the VCSE sector and other sectors play a really fundamental part in this, is sitting down with Paul and saying, Paul, what is it that would improve your life? And then how can we help wrap that around you to get you into a better place to live your life? And in terms of how services are designed now in primary care, we have people like social prescribing link workers. Here in the council, we have support planners. We have incredible, strong VCSE sector. And what they did for Paul was to sit down, talk about what mattered to him most. They got him debt advice, benefits advice, started to build his confidence, get emotional and mental health support. And he's at the point now, not that it's all fixed, but he's at the point now where he is actually volunteering in a role. And that's to just sort of give you an example about how differently we have to think about these things. I've mentioned how important the voluntary sector is, and again, it's not me to own, but literally all of us here in Northumberland need to find better ways to work with the voluntary sector and resource the voluntary sector, because they're in a pivotal place to work on this. I do just want to talk a little bit about healthcare, because the whole of health now needs to embrace different ways of working that's not just fixing someone and getting them back out there into their lives. So what we've done here in Northumberland is you'll be aware that we now have 7 primary care networks, and basically what they are clusters of practices based around neighbourhoods and communities. And what we've done with each of them, I'm just going to, and maybe Graham can help me give some flavour to this. But every primary care network, what they've done is they've done some analysis of data, which is really important in terms and linking data sets. So not just looking at our health record, but looking at all of the other things we know about police, about the local authority, about anywhere that information's held about us, to learn what matters. And each of those 6 or 7, there's primary care networks have chosen some topics, not only based on data, but on conversations with local people about what matters to them. So if you look, for example, there, very much down in the southeast corner, there's a real big focus around best start in life and self-harm, and the evidence points really significantly in our emergency settings around admissions that are avoidable, and also intentional self-harm. So I'm not saying it's the only topic in that area that matters, but what we've done is help fund primary care networks to take a really good look at that. Liz and her teams and the wider VCSE sector will be involved as well in terms of that. You go down the list, you can see topics that really matter to us all. But we have a challenge now, which is we talk about inequalities a lot. It's translation to action. What are we going to do here that matters, that's going to have an impact? That isn't just us doing to other people. So you can see other topics up there are about child poverty. And we mentioned about how that's only going to get worse in the next couple of years. I'm aware in the Queen's speech there's the whole levelling up agenda coming. We need to be like right on top of that, getting the resources in to help us here. There's a term there that's frequent flyers. What that really means is there's an incredible amount of some of our population who use services more than anybody else. So what we find is, for example, in that network, Valence, which covers a 50,000 population, what you'll have is about 30 to 50 people in that who literally access services tens, hundreds of times. Now, that's a symptom of how their life is and what's going on in their life. So we kind of want to start finding those people, sitting down with them, talking about what matters to them, and then working with them around how we help them change their life to live in the way that they want to live. I could go on, but there's others up there as well. It's literally a start. The other thing that we've done, and this is very much about system working, is, again, just another technical term, Section 256. Basically what it means is an agreement together between Health and the Council to fund, to quite a large degree, a lot of this work around inequality. So we have pooled a lot of money, and I hope we can get more. And the trick now is to get out there, find what matters to people, and get going. And that's the challenge for the next year. And just to kind of emphasise, this is an environment where lots is happening in this geography. It's that Health Inequality Summit led by the leader and the council, our inequalities plan that we need to work up, all of the money that we've put into this, the voluntary sector, really important, and what we're doing now around children, young people's integration work and best start in life, which has always figured really strongly for us. They're all the things we need to get onto and get acting on and see if we can change some of those levers and outcomes that we have where someone dies 10 years earlier than they would if they lived in a different part of the county. And just in terms of action, what have we done already? We have. There's a brilliant project on creative health. It's been presented in quite a few places. We've approved that. That's going on. That's brilliant. And when I say we, I mean us as a system. This is not just one organisation thing. All I want to emphasise really is that all of this language around population health management, inequalities, actually we're talking real people, real communities, and I think we're starting to see the seeds of really strong action that matters. So I'm happy to take any questions.
Thank you, Siobhan. Julie.
I just want to say, Siobhan, thank you so much for that, and we really appreciate the work that you're doing and intend to do with the voluntary and community sector, and I think that social model that you're obviously going to be investing in around prevention is exactly what the third sector does. They're the front door to the local communities and they're well placed to know the needs and what we need to do to respond to them. So I find it very refreshing, so thank you for that investment in time.
David.
Thank you. Just very quickly, and thanks for the presentation, Siobhan. And obviously there are a lot of people, as we've just heard there, who are committed to this whole agenda, you know, which is very, very reassuring. But just as I've mentioned before, just a plea that, you know, there's tangible action taken to integrate all of this, because a lot of well-meaning people, a lot of well-resourced organisations putting a lot of time and effort, experience, expertise into this whole agenda. But I think it needs to be complementary, you know, rather than duplication. Not an easy task when so many people are striving to move forward on this, but I think it's very, very important when, you know, capacity within the health service is being stretched, when funding is, you know, not always as we would wish, but just a plea that an emphasis is placed on doing this together rather than duplicating effort, which would not be the best way forward. But just wish you well on this journey, because it's very important and a lot of people are putting their heart and soul into it, which is great.
Thanks, David. I'm desperately looking around my desk to find the sheet that has the terms of reference on it, because I think one of the first lines of the terms of reference for this group is to make sure that the system does what's needed for the well-being of the people of Northumberland. And I think your point just illustrates that it is all of our responsibility to work out how we work in partnership with everybody else to make sure we avoid exactly what you've said. And I think we did we recognised probably 6-12 months ago that because population health management was the buzz thing, everybody had set themselves out to do it because it felt like the right thing, and there were enthusiasts within each organisation that set away and there were champions. And what we've worked over the last 6 months, I think, by talking at System Transformation Board, our ICS will put an expectation on us as well to do this together. Hopefully our area-wide integrated care partnerships will also ensure that we all do this in a similar vein. So not just Northumberland, North Tyneside, Gateshead, that we'll all work out that it's a coordinated together thing. So you've got a really valid point, and we just have to keep reminding ourselves, are we including the right people? Are we all doing this together? One of the things that will hopefully come of our more integrated working is we can actually share our financial or human resources in a more meaningful way to do it as well, because we're all doing it within a potentially constricting funding bracket as well. We all know that we're under pressure to control our spend and use our resources as best as possible. Okay, thank you, Julie.
Just briefly, could I just make a point on what you've said there? And I really welcome the fact that we've got, you know, the new thriving communities and the health and wellbeing network, everyone striving together in the third sector to work with the statutory sector. I think it's about an investor-save model very much. And I think what also needs to be recognised in this is how much external funding that the voluntary sector actually brings into health. You know, millions and tens of millions of pounds every year will be brought in by the third sector to be doing low-level support work within communities, which is very important. So I think it's about what the third sector can bring to the table as well. We're not always standing with a begging bowl. We're here to share ideas and say, well, actually, which I've done in the past, we can bring some money to fund that project or pilot something, you know, on a small scale, obviously, but it's about that true partnership and working with each other collaboratively for the best outcomes for people, and get rid of the politics, and let's just work together, which we're striving to do, all of us.
Thank you. And I think looking at a person and what this means to an individual is often one of the most useful things, because all of our organisations can probably identify a person who this matters to. Yes. And that's when it illustrates the point of what you're trying to do, because otherwise there is a bewildering array of terms and phrases and NHS speak that can actually just get very confusing about what it's all about, and then you can't see what's actually being done, which comes down to output and outcomes. Okay, thank you. David?
Just one final point. You know, Siobhan mentioned £6 billion within the North East North Cumbria system, which is a lot of money, but it has to go a long way. And you also mentioned, you know, Siobhan, getting the resources in, because it does take money to enable this to happen. And I just trust that the Integrated Care Board, which also has health inequalities as one of its priorities, will actually already have determined, you know, a reasonable amount of money, you know, for this whole programme on health inequalities, because they hold the purse strings, and I really do hope they have allocated sufficient resources from that central pot to enable primary care networks, counties, sub-regional partnerships, etc., to get on with their work. I don't know what the figures are, but I hope sufficient resources have been allocated specifically to this programme beyond hospitals, GPs, ambulances, mental health and so on.
So we don't have an ICS update on the agenda today, and I don't think we should try to do that today. However, the operating framework for the ICS and the delegated responsibilities back to Northumberland, one would hope that within the delegated responsibilities is our ability to use some resources that we think we can best direct. Yeah. So, and that's what we as Northumberland need to try to ensure that our ICS enables us to do. Are we finished on that agenda item? Yeah, thank you very much, Siobhan. That was really helpful. So, now having turned all my papers upside down, I think we're on to the forward plan. Correct me if I'm wrong. So the forward plan, we have some people coming to the next meeting, which people can see, but I do think there is a piece of work to be agreed with the new chair around a development session to work alongside. I think there's something about reviewing our terms of reference to ensure they're fit for the purpose of what we want in Northumberland, and they may well be, but there's then something about participation of members of this group. So reviewing who's been attending, and does that allow us to do the job that we want to do, and then how does that inform our system in terms of how we would like it as health and wellbeing to work, and who works into that system. So that would be something that myself and Liz, I'm sure, will raise with the new chair to see what time we can put aside to actually look at some of those issues in the coming months. Would everybody be happy or in agreement with that process? Yeah, good. Thank you.
Graham,
yeah.
Within that, I think this has been covered. I would imagine that within those discussions there will be a debate about how the Health and Wellbeing Board, how it links into the sub-regional partnerships in the ICS,
Yes.
because you know that's part and parcel of it, and the overview and
Yes.
scrutiny committee if need be. I'm sure that would be part of it.
So the
Just to make sure
sub-regional part of the ICS, I would be looking to Mark Adams really to be looking at our area, because he is our board member of the ICB for our area of the ICS, to ensure that our ICP and the people within it are all getting those links correctly made. There was also a question that's been raised, which I would look more to my council colleagues around: where does OSC committees fit in how we all relate to each other? Because if we have committees which are holding to account for provision of services and things like that, they actually need to understand how the system is working so that they can hold us to account in the right places and put the right checks and measures in place for their point of view. And we've obviously got quite a lot of changes in organisation, and with any change there's risk around governance, and we have to ensure that safety aspects are correct, all of those checks and balances. So if there's a new checks and balance system within the NHS and the partnership system of working, what checks and balances are required and where are they accountable to? So I think, again, the chair of this board probably needs to understand how things escalate or get taken to our OSC of various committees. Okay, good. Any comments on any more of that? No, we haven't got any prior urgent business. Anybody wish to raise anything? No, and the date of the next meeting, Thursday the 9th of June, 10 a.m. at County Hall at present. One of my other thoughts is, do we wish to continue to keep meeting in County Hall? There may be technological reasons or other reasons why that would need to be, but then I would like to explore options of how we might have health and wellbeing occurring in other parts of our county, more in the community. So one idea was the community hub in Cramlington, for example, has a really good meeting room on the top floor. But there might be other options that I would like to explore if other people were willing to look at that. Yeah. Okay. Meeting closed. Thank you very much.